Okay, okay. So I welcome all the participants, including our speakers, panelists, and with all the delegates to this 22nd TUGSS India academic program. This program we are running from last 2 years, and with this today's session, we are completing this second year as well. Today we shall be discussing the basics of liver surgery, which would be very useful to all the general and GI surgeons who are focused on HPB and transplant surgeries. I hope our panelists will make these sessions very interactive. And after all these three talks, we shall be having question and answers from our delegates, and even the panelists can keep on discussing about the topics. So with this, I shall invite our first panelist, who is Dr. Apurva Deshapande, who is a consultant in HPV surgery, Sahyadri Hospital, Pune. Our second panelist is Dr. Mayank Jain, surgical gastroenterologist in Agrasen International Hospital, Delhi. He has a very special interest in GI oncology. And we are missing our third panelist, Dr. Divyajyoti Bora, who is consultant HPV unit in Apollo Hospital, Guwahati. He has been stuck in some post-op case care, so he may join us in I think in between of the session. With that, I welcome to our first speakers, Professor Dr. Dinesh Balakrishnan, sir, in the Department of GI and Solid Organ Transplant Surgery in Amrita Hospital, Kochi. He is senior surgical gastroenterologist who has been clinical fellow in his subject in Edinburgh, Cambridge as well. And today he is giving to guide us and discuss about the detailed anatomy of the liver. So over to Professor Balakrishnan, sir.
Thank you, Dr. Vikas. I've kept it very basic, and I think we'll do the presentation and then interact. So can I start? Am I audible?
Yes, please go ahead.
Yeah,
please
okay.
Go ahead.
So thanks for this opportunity. I'll start with my presentation. So as you all know, liver is one of the largest glandular organs in the body. It's located in the right upper quadrant. It's invested by the Glisson's capsule. And there are various ligaments which attach the liver in place, like the falciform ligament, which becomes the right and left triangular ligament. These are not actual ligaments. They are condensation of areolar tissue and the Glissonian sheath, which keep the liver in position. So the liver is divided into two hemilivers, a right and a left lobe, by the main lobar fissure. So this is a line which I can show in a subsequent diagram. This is a line which goes from the gallbladder bed to the IVC. And this divides the liver into two hemilivers, a right and left hemiliver. The right lobe of the liver, the hemiliver, is about 60% and the left lobe is about 40%. And it is in this line that the middle hepatic vein lies. The middle hepatic vein drains both the right as well as the left side of the liver. Now, the inferior surface of the liver is closely related to the stomach through the gastrohepatic omentum, in which a branch of the vagus nerve, the hepatic branch of the vagus, and sometimes the left gastric artery is there. It's also related to the stomach and the duodenum, the hepatoduodenal ligament, in which the porta hepatis is there. And as you can see in this picture, behind the porta hepatis is the foramen of Winslow, through which you can enter the lesser sac. So these are the visceral relationships of the liver. So and in the hilum of the liver, the porta hepatis, as you can see, is the bile duct anteriorly, and behind the bile duct is the hepatic artery, and posteriorly is the portal vein. So as we all know, ultrasound today is an extension of the physical examination. So I would also share a few pictures of an ultrasound view of the liver. The liver on ultrasound is a homogeneous mid-gray organ. It has the same or slightly increased echogenicity when compared to the cortex of the right kidney, and slightly lower echogenicity when compared to that of the spleen. So this is a longitudinal section through the right lobe of the liver. The renal cortex, as you can see, is less echogenic than the liver parenchyma. So the portal vein, the hilar structures enter the liver, and they're invested by the Glissonian sheath. So here you can see the bigger structure is the portal vein. And sorry, just a second. Yeah, so this is the portal vein, and the portal vein is associated with the branch of the hepatic artery and the bile duct. And the echogenic structure, the hyperechoic fibrous sheath, is the Glissonian sheath. So the portal vein is invested by the Glissonian sheath. Unlike that, the hepatic veins are not invested by any tissue. So their walls are imperceptible and merge with the hepatic echogenic hepatic parenchyma. The size of the liver, as you know, is like anywhere between 10.5 plus minus 3 centimeter in the mid-clavicular line. And in the anterior superior measurement would be around 8.1 plus minus 3.8. So Claude Coina has described the segmental anatomy of the liver. And as we all know, the liver is divided by the Cantil's line to right and left hemiliver. And each hemiliver, the right hemiliver is again divided into sectors. The anterior sector, which is made of segment 5 and 8, and the posterior sector made of 6 and 7. It has got a medial part, which is segment 4, which has an A and a B, and segment 2 and 3. The middle hepatic vein drains 5 and 8 as well as 4A and 4B. So the segmental anatomy of the liver, essentially anatomical liver resections are possible because each segment is supplied by a radicle of the portal vein, hepatic artery, and the bile duct, drained by a hepatic vein and a bile duct. So coming to the radiological anatomy, so if you take a cut at the level of the hepatic veins, then you have segment 2, 4A, 8, and 7. So why do you have to know this? Basically, based on this, we can say in which segment a particular tumor is located. If you come a slightly lower cut of the CT, then you can see the junction of segment 2, 3, 4A, 4B, and 7, 8. Similarly, if a cross-section is taken at the level of the porta hepatis, one would see segment 3, 4B, segment 5, and segment 6. The caudate lobe lies between the portal vein and the IVC. So this is the caudate lobe. So radiologically, what I have shown in the previous diagram, this is like basically the level of the hepatic veins. And you can see segment 2, this is segment 4A, that's 8, and segment 7. Similarly, at the portal vein area, that's the portal vein, you'll see 3, 4B, 5, and 6. So this will help us to know in which segment a particular tumor is, and will help to do a segmental resection of the portal vein. I mean, a segment of the liver. So basically, when you're thinking of imaging, you consider doing a triple phase CT scan. Basically, there's a plain scan, which will help you to identify calcification or know how fatty your liver is. The arterial phase, which is the first picture, is done at about 30 seconds. Usually it helps to identify hepatocellular carcinomas because they are largely supplied by the hepatic artery and will enhance brightly in the arterial phase. Now that's the portal venous phase at 45 to 60 seconds, which shows the posterior sectal branch of the portal vein. And at 90 seconds, you can see the portal vein as well as the hepatic veins. So you can identify the particular tumors based on the phasing of the CT, and the phasing is usually done in these 3 phases: an arterial, early arterial, a portal venous, and a hepatic venous phase. Now, when you do an ultrasound, you can see that the right hepatic vein joins the cava, and then the middle and left, usually in most of the patients, the middle and left joins to form a common trunk. There can be an umbilical fissure vein which separately drains segment 4. So in 15 to 35% of patients, the left hepatic vein and middle may have a separate opening into the cava. Now, all this is important when you are consider doing a donor surgery. Like if you want to take a segment of the liver with its outflow, you have to have a sound knowledge about the inflow as well as the outflow. As I mentioned before, the portal vein is contained within connective tissue sheath, the Glissonian sheath, which gives it an echogenic wall on ultrasound and distinguishes it from the hepatic veins. Now, that's the portal, right branch of the portal vein on ultrasound. So that's the portal vein, and behind what you see here is the cava. That's a pictorial diagram of the portal vein and the cava. And between the portal vein and the cava is this is where the caudate lobe would lie. So on ultrasound, that's the main portal vein and the right and left branch of the portal vein. Now, that's the left branch of the portal vein, which forms an umbilical portion. It's like the H. And that's segment 2 branch of the portal vein. That's segment 3. This is 4B. This is ligamentum venosum. And ligamentum venosum separates segment 2 from the caudate. So this anatomy, knowledge of this anatomy helps us to do monosegmental resection. Suppose you are doing a liver transplant for a baby with biliary atresia and you have to take a segmental liver graft. Then you have to you can reduce the graft. If you are taking the left lateral, you can reduce the graft by ligating this branch of segment 2, and then you can have a segment 3 graft, or take out this part and then have a segment. So you can have a monosegmental graft if you have a sound knowledge of the anatomy. Now, that's the portal venous supply of the right side. That's the right branch of the portal vein. This is supplying segment 5 and segment 8, and this is supplying segment 6 and 7, and the limb of the H is formed by the right branch. The normal portal vein diameter is highly variable, but usually it does not exceed 16 millimeters in a resting state on quiet respiration. If the portal vein diameter is more than 16, one should suspect that the patient is having portal hypertension. The predominant portal vein input to the liver will cause maximum liver enhancement during the portal venous phase. Now, a brief mention about the embryology. The portal vein, at about 4 weeks of life, the portal vein starts developing from the vitelline vein, and they pierce the septum transversum. And later, as the embryo grows, some of these veins will whittle away, and then it gives rise to the superior mesenteric, the splenic, and the portal vein. So the first to arise is the portal venous system in the embryo. And if there are any variations in the portal vein system, then because the portal vein drives further development, there will be variations in the hepatic artery as well as the bile duct. So if you see variations in portal vein anatomy, one should suspect that there can be variations in the bile duct anatomy as well. Normally, the portal vein divides into a right branch and a left branch, but you can have a trifurcation. Here you have an anterior sector, a posterior sector, and the left branch of the portal vein. This is a trifurcation pattern. You can have the posterior sector joining low down on the portal vein, where you'll have the anterior, posterior quite separated out. Or you can have a anterior sector joining the left, where you may get the limbs close together. So this knowledge of these variations in anatomy is very important, especially when you're doing a live donor surgery to take a right lobe graft, because then you should be prepared to reconstruct the anterior posterior branch of the portal vein using the portal vein from the recipient. And if you do not have a recipient portal vein, for example, if the portal vein is thrombosed at the hilum, then you may have difficulty reconstructing these veins. Now, there are many variations of the portal vein, and some variations are a contraindication to donation. For example, you can have a single portal vein which supplies each segment of the liver. Like, it will be a single trunk, and then you have branches going to segment 3, 2, 4B, 5, 8, all separate branches. And this is an absolute contraindication to donor surgery. Now, coming to the hepatic artery, it lies anterior to the portal vein and to the left of the CBD at the free edge of the lesser omentum. In 55%, the common hepatic arises from the celiac axis and divides into a right and left hepatic at the porta hepatis. In 45%, there can be variations in anatomy. The usual variations are the right hepatic artery, sorry, it's a replaced artery arising from the SMA, or the common hepatic can be completely replaced and from the SMA, or the left hepatic artery may arise from the left gastric artery. Now, sometimes you do not have a celiac, you have a common celiomesenteric axis. The celiac and SMA are a single trunk, and all the arteries arise from there. So there can be many variations, like Mitchell has described around 16 variations of hepatic artery anatomy. That's the normal anatomy here. The celiac axis giving the left gastric, the splenic artery, the common hepatic artery, that's the gastroduodenal trunk, proper hepatic dividing into a right and left. You can have right hepatic artery completely replaced from the SMA. You can have the left hepatic artery arising from the left gastric. You can also have accessory arteries where you have a replaced artery from the right, but in addition, you have a accessory right or left hepatic artery. Now, coming to bile duct blood supply, as early as 1970s, Northover and Terblanc has described the axial blood supply of the bile duct. You have the 3 o'clock and 9 o'clock artery. So most of the supply is from the posterior superior pancreaticoduodenal artery, the retroportal artery, and the gastroduodenal. So this constitutes about 50 to 55% of the blood supply of the bile duct. The upper part of the bile duct is supplied by the right hepatic artery in about 25% is contributed by the right hepatic, about 7 to 8% by the cystic, and 3% by the left hepatic. So there is an axial blood supply, and there's a rich intramural plexus of vessels. So when you're cutting the bile duct, one should be careful. You should not cut with a lot of cautery in the bile duct, because this can lead to thrombosis of the vessels and ischemia of the duct and subsequent stricture formation or a leak. Coming to the biliary system, as you all know, the bile duct constitutes of a common hepatic duct. There's a supraduodenal part of the bile duct and an intrapancreatic portion of the bile duct. Now, when you're doing an ultrasound, you need a color Doppler to distinguish the hepatic artery from the duct. If the third or higher order ducts, like after the primary confluence, further into the liver, if the third or higher order ducts are seen on ultrasound, then you can say that there is intrahepatic biliary radical dilatation. Essentially, it means that there is an obstruction in the bile duct. Now, the normal diameter of the first order or second order duct is less than 2 millimeter and no more than 40% of the adjacent portal vein diameter. But if you have a bile duct obstruction, then you have a bile duct which is almost the same size as the portal vein. This gives rise to various signs on ultrasound, like you can have a shotgun sign where you see two parallel structures when you do an ultrasound. The portal vein and the bile duct are of equal caliber. The normal bile duct is about less than 7 millimeters, but in the post-cholecystectomy state and in the elderly, the bile duct can be up to 10 millimeters. If you have a bile duct which is more than 12 millimeters, one should suspect that patient probably has a formafrostate choledochal cyst. And this is an ultrasound showing the portal vein and the bile duct parallel to it. Just anterior to the portal vein, you have the bile duct. Now, if this is as big as a portal vein, then that means that there is an obstruction to the biliary system. The gallbladder on ultrasound is an oval sonolucent structure. Usually the wall is 2 to 3 millimeters, thin, smooth wall. Length is about 8 to 10 centimeters. So if you have cholecystitis, there is a thickening of the wall. It may be more than 5 millimeters, and there is pericholecystic fluid. So the normal wall is only about 2 millimeters, and any thickening, one should suspect. So uniform thickening, it is a cholecystitis. If you have focal thickening, one should suspect that there is a malignancy of the gallbladder wall. Cystic duct 3 to 4 centimeters, caliber is only 2 millimeters. The spiral valves, the valves in the cystic duct. The relationship behind the cystic duct is the portal vein, medially the common hepatic duct, and above and lateral is the cystic artery. Now, there are many variations of the bile duct anatomy, and one should be aware of the variations in anatomy. Usually the bile duct divides into a right and a left duct. And then the right duct divides into an anterior sector, which is basically the biliary drainage from 5 and 8, and a posterior sector which drains 6 and 7. The caudate lobe drains into both the right as well as the left side, equally to the right and left side. Segment 4, 2, and 3. So this is a normal anatomy which occurs in about 50% of the Caucasian population. There are many variations, and you can have anterior, posterior, and the left duct forming a trifurcation, where if you're doing a right lobe graft, you can get 2 ducts on a plate. This is type 2 anatomy. Type 3, you have a posterior sectal duct which is crossing. This is a crossover anatomy. It crosses the hilar plate and goes to the left side. You can have the posterior sector joining the common hepatic duct. You can have the entire posterior sector joining the cystic duct, or the entire right system joining the cystic duct. The anterior may sometimes join the common hepatic. So there are many variations in the bile duct anatomy. Some of these variations can lead to injuries during surgery. For example, the posterior sector joining the cystic duct. Now, during gallbladder laparoscopic cholecystectomy, you may accidentally injure the posterior sectal duct, especially because of the perception, the heurism. You imagine that this is because of inflammation and all that. You imagine that this is the cystic duct, and then you clip it. This is type 6, which is again a very rare variation, but sometimes you have come across this. You have the segment 2, 3, and segment 4 draining into the right system. Now, when you are looking at the hilum, you may see that this is the right and this is the left system. And you may accidentally, start dividing here, thinking that that's the right system during a right hepatectomy and subsequently you may come across the other ducts which drain into the right system. So you have segment 2, 3, and 4 draining into the right. This can lead to injuries during surgery. We have come across a similar anatomy in the donor where we thought that it was a laparoscopic, I think it was a robotic surgery, and we found on ICG cholangiogram, segment 3 and right we thought was the hilum, the bifurcation. And when we went and cut here, caused an accidental injury to the duct, and we had to do a Roux-en-Y reconstruction. Now, the Glisonian sheath forms plate system. This is the hilar plate. And the entire length of the primary branches of the portal vein or the hepatic duct and the second order radicals lie below the plate. So knowledge of this anatomy is also very crucial, because if you lower the plate, then you can loop the primary confluence as well as a second order confluence. And with this, you can demarcate a particular sector, like you can demarcate the anterior sector and do an anatomical resection. So that's, you demarcate the anterior sector and posterior sector separately, and you can do an anatomical resection. So there are the different plate systems: the hilar plate, the cystic plate, the umbilical plate, and the Aranchin plates. So through the various plate systems, one can have access to the liver and do a segmental liver resection. Another point is that any variation of vascular or biliary elements usually occur under the plate system. So dissection of Glisonian elements above would be, you will lower the risk of injury to elements of the remnant liver. I'll just show you a picture to illustrate this point. Here you have a posterior sectoral duct joining the left. This is the classical crossover anatomy. If you're doing a left, for example, a donor surgery, you're doing a left hepatectomy as a graft, then if you lower the plate and go above, so the posterior sector will always join below the plate system. So you have to lower the plate and go above the plate system and cut the duct here so that you do not injure the duct. If you presume that this is the bifurcation and cut here, then you, again, on further going up, you will come across the posterior duct. You may injure the posterior sectoral duct. So you lower the plate and go above the plate system so that you do not cause any injury if there are anatomical variations. Now, there are different variations of the venous drainage also. The normal anatomy is the right hepatic vein drains into the inferior vena cava. The middle and left hepatic in 15 to 30% drains separately. You can have a accessory inferior right hepatic vein. So again, during a donor surgery, all this becomes very important. For example, if you have multiple veins draining the right lobe of the liver, then during reconstruction, you have to reconstruct each of these tiny veins into the cava. And many of these veins are of low caliber, and if they thrombose, then the graft is at risk of outflow obstruction. So clear radiological anatomy of the inflow as well as the outflow is very important, especially when you're doing live donor liver surgery. So usually the middle hepatic and left joins together as a common common trunk. This is the umbilical. Sometimes there's a very good umbilical fissure vein which drains separately the segment 4, and the MHV is predominantly drained by drains segment 5 and 8. In these sort of cases, you can take a larger part of the MHV. But if you do not have an umbilical fissure vein and segment 4 is draining into the MHV, then you can take only a subtotal part of the MHV. So again, all this has relevance in donor surgery. So again, a CT picture showing multiple hepatic vein outflow of the right lobe. So this sort of a graft is difficult to reconstruct. One may have to do bench work and then sort of put these grafts together on a venous cuff. Otherwise, individually doing these into the cava invites risk of thrombosis and outflow obstruction. Again, this is just put this picture to show that the relationships of the inferior surface to the kidney, the adrenal gland, the duodenum, and the hepatic flexure. So here you have a large tumor, which appears to be like a tumor arising from the right lobe. But actually, this is not a right lobe tumor. This is a tumor arising from the adrenal. So this can be diagnosed based on the blood supply. So you have the artery arising from the aorta supplying the adrenal, which is supplying this tumor, and not the artery arising from the hepatic artery. So these are adrenal tumors one should suspect before surgery, because if they are a functional tumor, then you have to optimize this patient and work them up well and prepare them before surgery. Otherwise, you may have a crisis during the intra-op period when you start handling the tumor. So that's a team at Amrita with that's a team in which I work. A lot of people and a lot of teamwork involved in doing work in the hospital. Thank you for this opportunity. I've just touched upon some of the points. I would be happy to answer questions. Thank you for this opportunity. Hello.
Thank you, Professor Balakrishnan, sir. Yeah,
Thank you.
yeah. Am I audible?
Yes, very much.
Am I audible?
Yes.
Okay. So, Dr. Balakrishnan, it was really a nice presentation. We were expecting the anatomical part, but you have covered the radiological part as well. So it was really a nice presentation. So we shall be taking the questions after completing 3 talks, if you are available.
Sure. I'll be available, but I'm just leaving hospital. I'll be on the phone. I'll take the questions.
Okay, sir. I think after 2 talks, we shall be taking. So by that time, you will be reaching there.
Sure, sure. Thank you.
So now I invite our second speaker, Dr. Kanchan Sachanandani. She is a consultant in HPB and GI surgery in Jupiter Hospital, Pune. She received a special fellowship from TMH Mumbai and is also the Best Young Scholar Award from Amasi in 2022 and the Young Surgeons Award of GI Surgery in 2019. So today she is going to deliver a lecture over the different type of liver resection and its technique. Over to Dr. Kanchan.
Thank you very much. I'll start sharing my screen.
Yes, definitely.
Okay.
I'm not able to share my screen. Just give me a moment.
Not keep it out of word.
Keep audio. Keep the outside. Look, audio. It's not. No, no, I'm not giving a you put. I'm not getting anything. Audio is also not good. I think it's not coming. It's coming.
Dr. Vikas, can you start with the next presentation? Meanwhile, I'll just see what is happening with the screen. I'm not able to share my screen, or should I mail you and you will be able to share the screen?
Okay, we shall start the next session meanwhile. And by the time, may I know what exactly is happening? If we can help.
Some security, I mean, some system preferences are not there in the laptop, it seems. So I'm just juggling with that.
Okay, I'll message you my email ID. Just share that one on there.
Yes, yes, yes.
Meanwhile, we will start with the third session. And for the third session, I'll invite my co-host, Dr. Somil Vyas, who has been there with us in TUGSS India team for last 2 years, and he's the active surgeon in Paradise Hospital in Mumbai. Dr. Somil.
Yeah, thank you, Vikas. I would just share my screen now, and we would this thing. Just let me know as you see my slide presentation. Is it visible?
Yes, it's visible.
Okay, slideshow from the beginning. Okay, fine. So it's a pleasure to speak again on this particular forum. Vikas has been doing an excellent job of coordinating these monthly sessions right since we started, and the academic content has been exceptional. So today I would be speaking on how do we really assess a patient and understand as we plan for a liver resection and major liver surgery. I can't speak of liver resection and liver surgery without discussing cirrhosis. So as is known, there are multiple causes of cirrhosis. We now have newer and newer definitions coming in. What started as non-alcoholic fatty liver disease, we now have a concept called metabolic fatty liver disease, metabolic associated fatty liver disease. So NAFLD is being replaced by MAFLD. There is an alcohol associated liver disease, etc. But essentially, all of these conditions lead to cirrhosis. Cirrhosis does lead to the development of hepatocellular cancer. 90% of all HCCs arise in the background of cirrhosis. And by itself, this poses a great problem because along with treatment of the HCC, we are also treating the cirrhosis. We have a compromised liver function, and one then needs to find a middle path to treat the cancer without disturbing the liver, and at the same time treat the cirrhosis. And we'll discuss this as we go along. So normally when we come across a patient with cirrhosis, we do the standard set of blood tests, a complete set of blood tests, including the synthetic function, INR, bilirubin, and the albumin, along with the rest of the renal profile, etc. We perform a CT scan and an MRI, calculate the Child-Pugh score and the MELD scores, which are essentially based on the synthetic function of the liver. And then there are some advanced tests, what we call as indocyanine green clearance. We could do an HVPG to measure the portal hypertension. There are now certain non-invasive methods of assessing portal hypertension coming through. And we again could do a liver biopsy to understand what is the magnitude of liver damage that we are looking at. This is the updated BCLC classification brought out in the Journal of Hepatology just last year, 2022 update. And although it's a complex slide looking at the treatment of HCC, what essentially it is telling us is that the treatment of HCC is very much, apart from being dependent on the tumor volume and the tumor burden, it is also dependent on the liver function. So the function of the liver does dictate to a very large extent as to how HCCs will be treated. And this is where I would like to say that you need to look at the liver function very closely when treating any liver tumor. Whenever you discover a tumor in the liver like this, either a patient is symptomatic or it's a chance discovery on ultrasound, you basically do the standard set of blood tests, do the standard set of tumor markers, CEA, CA19-9, alpha fetoprotein, CA125, do a complete virology screen. An initial imaging is very often an ultrasound, and then it goes on to progress into a CT scan, MRI, and the PET CT scan. It was very correctly demonstrated by my previous speaker that you ideally require a triphasic CT scan or 4 phases, a non-contrast, an arterial phase, portal venous phase, and a hepatic venous phase or a delayed phase to very correctly understand the vascular patterns of the tumor. This is particularly so more relevant in cirrhosis, and subsequently you go on to decide as to what kind of tumor we are dealing with. And once you have that, you can basically go on to do an endoscopy to rule out varices or plus minus any other findings, do a liver biopsy, and we have discussed the rest of the tests. And this is what a very good radiologist can give us. This was shown even in the previous pictures and is very relevant not only to donor surgery and planning of living donor liver transplantation, but also if you want to plan out your liver surgery for a tumor in a non-transplant setting. It is always very good to have reconstructed and reformatted images of the vascular tree, particularly the arterial phase, the venous methods, and the portal vein, along with a very good MRCP to show the biliary anatomy, because one can minimize the complications, one can plan out your surgery very well, and of course, make appropriate measures to encounter difficulties during the operation. So a good radiologist showing these particular things is paramount and optimum. Now, how do you really go on to assess the liver function? There is a set of what we call as static tests, and there are what are called as dynamic tests. And it is essentially like saying, just comparing it to something like an ECG. An ECG is a static test for the heart, while a 2D echocardiogram or a dobutamine stress echo or a thallium stress test would be a dynamic test. By the same logic, you have a static test here, which shows your blood tests, and a dynamic tests are actually looking at how the liver is functioning, which means it's a real-time assessment of how the liver is able to detoxify various substances. And you could do this through a variety of methods. The most popularly known test is the ICG clearance test. There is also another test which is popularly used in the West, what is called as the Limax test. We don't use it, I think, in this country, but I would just explain a little bit about it as we go along. So the liver essentially has what we call as a synthetic function, and that essentially means how well it is able to neutralize the bilirubin and keep the bilirubin at excrete it out, how well it is able to synthesize albumin, and finally how well it is also able to give you the INR and produce coagulation factors, which is reflected in the INR, particularly vitamin K dependent factors 2, 7, 9, and 10. Hepatocellular injury is interpreted by the transaminases, and here again you have the half-life of these transaminases, and depending on and you would always have a situation where the ALT levels will be basically a little bit more elevated for a longer length of time as compared to AST. And then of course you look at portal hypertension through pancytopenia, etc. Based on these synthetic parameters, we have the Child-Turcotte-Puce staging system, child A, B, C, point-based. And again, what you are essentially dealing with is the synthetic function, bilirubin, albumin, prothrombin time. Greater the elevation, greater are the points allocated, which means worse is the liver function. And along with that, you look at the encephalopathy and the ascites, which whether depending on how much exists and whether you can keep that. So higher the score, obviously worse is the liver function, which also suggests there is a greater degree of portal hypertension. And it is very clear to understand that greater the amount of the Child-Pugh score, one is likely to have a greater mortality at a very short interval. And apart from an independent mortality from cirrhosis, if you subjected these patients to a liver resection, you can look at the prohibitively high incidence of mortality after a liver resection. So even for a Child-Pugh score A, you are going to have almost a 10% mortality, and that will progressively rise to 1/3 of patients and majority of patients with an increasing Child-Pugh. The MELD scoring system was devised at the Mayo Clinic Again, it depends on essentially the synthetic function of the liver. But what was done at the Mayo Clinic was that they essentially took away the albumin factor, because a lot of these cirrhotics were on albumin transfusions. This would interfere with the albumin level and lead to erroneous readings on the child-pugh scoring system. So originally the MELD score system was taken up to decide the mortality of patients on waiting list for a liver transplantation, and they replaced the albumin with creatinine, because creatinine essentially was also reflective of acute kidney injury or AKI in patients with cirrhosis. So you had scores ranging from 6 to 40. Normal minimum score would be 6. That would be in the context of normal liver function. And you could look at the mortality, which would rise from 7% to almost 90%. So greater the MELD score, again, greater is the risk of mortality. This is a 3-month mortality in patients who would be on the waiting list for a liver transplant. And therefore, greater the MELD score, greater is the prioritization for liver transplant in units and in countries which follow a MELD-based allocation. So you could look at again this, and this is again a very helpful indicator for patients who undergo or who are being planned for a liver resection in the background of cirrhosis. Because this would help to prognosticate and understand what is the risk of mortality in patients who have high MELD. So I would come to this now. The indocyanin green test is a very dynamic test, which is often underutilized, but has got quite a useful relevance, especially when you are planning liver surgery. It is used very often in the Far East, particularly in Japan and Korea. And fundamentally, the principle remains that when you inject ICG into a peripheral vein, it's a dose-based injection, about 0.5 to 0.7 milligram per kilo body weight. The ICG is taken up in the blood, it gets into the liver takes up the ICG, and what it does is it metabolizes the ICG and secretes it or excretes it out into the biliary tree. And that is why you see there is a very strong role for ICG cholangiography now, because almost after an hour, you would see, in a normal individual, you would see most of the ICG being excreted into the bile duct, and ICG cholangiography and fluorescence cholangiography is being picking up big time for looking at the biliary system during a cholecystectomy. So under normal circumstances at 15%, just about 4 to 10% of ICG should remain in the peripheral blood. And this is what we call as the plasma disappearance rate of the ICG. And therefore, what ICG R15 means is that 4 to 10% of the total injected dose of ICG remains in the circulating blood at the end of 15 minutes. And this particular estimations are done through spectrophotometry. It has to be done in a specialized biochemistry lab. Not every hospital will have it. And therefore, if you have anything more than 10% remaining in the blood at the end of 15 minutes, it would mean that this particular liver is not optimally functioning. And we do have cutoffs for minor and major hepatectomy. By definition, a minor hepatectomy would mean removal of 3 or lesser segments. Major hepatectomy would mean removal of more than 3 segments. And if you have an ICG clearance of between 15 to 17%, you could go in for a major hepatectomy. But if you have anything more than that, you could only perform a minor hepatectomy, and beyond that, you have prohibitively high risk. So the ICG is essentially a very dynamic test. You again have the kind of ICG kinetics here, but essentially what you're looking at is the ICG retention at the end of 15 minutes, which determines how safe it is to perform a hepatectomy. So here are some of the values here, that more than 40% is prohibitive for a liver resection. 22 to 40% will allow for minor resection, something like a small wedge resection. 17 to 22%. So up to 20% would be less than 3 segments. And you should not have an R15 of more than 15% to allow for a major hepatectomy. You, of course, if you have a biliary tract obstruction, you are going to get falsely elevated values, because you are clearly not going to have secretion of the ICG into the biliary tree. If you have hepatic artery thrombosis, again, the ICG won't be delivered into the liver, leading to falsely high values. Sometimes you could have a hepatic arteriovenous shunting within the liver itself, which will not allow for enough, which will give again a false negative report, because you get most of this ICG being washed out, and or you could have a false positive, in fact, because the ICG will continuously circulate into the circulation, and Gilbert syndrome, where the cells simply can't pick up the ICG to release that into the bloodstream. As we know, portal hypertension by definition means a hepatic wedged venous pressure of more than 10 millimeters of mercury. There are various causes of portal hypertension. I won't go into the details, but basically portal hypertension, especially when it is coming at a sinusoidal or a post-sinusoidal level, meaning it's either from the liver or post-hepatic, essentially would lead to compromised liver function. Pre-sinusoidal and pre-hepatic portal hypertension is a different pathological entity. I won't get into the discussion at this point in time. And the best way to understand the portal hypertension is to measure what we call as hepatic venous pressure gradient. So it's an invasive test. It is done by an interventional radiologist. You basically put a catheter through the jugular vein, wedge it into a hepatic venous pedicle, and then measure the pressure across the gradient, and then measure the gradient. So you measure the gradient into the wedged pressure from the portal vein and the hepatic vein. And when you have a pressure gradient which is more than 10 millimeters of mercury, it would mean that basically you are dealing with portal hypertension. Ideally, if you have a pressure of more than 6 millimeters of mercury, it would mean that you have subclinical portal hypertension, which is compensated, and this may not have much clinical relevance. But at the pressure of 10 millimeters of mercury, you start having varices appearing. And of course, as the pressure keeps on increasing, the incidence of variceal bleeding and other complications of portal hypertension keep on increasing. So where would you do this test? Ideally, you are looking to do this test in a patient who has suspected chronic parenchymal liver disease. He's got a liver tumor. You may want to resect him, or he's got chemotherapy-induced steatohepatitis with early cirrhosis, and you want to resect a tumor. On endoscopy, there are no varices, but you are unsure as to what the status of portal hypertension is. Then doing an HVPG gradient in this set of patients is ideal. You could combine it even with a transjugular liver biopsy, which will give an idea about the nature of the background liver parenchyma. And this is very informative in surgical planning. Again, grossly speaking, if you have esophageal varices, which means the portal HVPG is more than 10, the portal pressure is more than 10, you have a splenic span of more than 12 centimeters to suggest clinically significant splenomegaly, and a platelet count of less than 1 lakh. This particular triple combination again suggests that there is clinically significant portal hypertension, and this patient would obviously become high risk for surgical undertaking. So one of the commonest causes for resection in the liver is hepatocellular tumors. I won't go into the details, but obviously in the background of cirrhosis and chronic liver disease, surgical resection does become a high risk undertaking. Various criteria have been described to look at post-hepatectomy liver failure. And as I have described, the synthetic function of the liver is based on INR, bilirubin, and albumin. All liver failure scoring systems essentially look at the measurements of INR and bilirubin post-operatively, and higher the levels, the worse is the chance of them developing a liver failure. The best criteria known are the 50-50 criteria by Belghiti, where he said that if you have a serum bilirubin of more than 50 microgram percentage, that would roughly correspond to about 3.4 or 3.7 milligram percent. And if you had a prothrombin index of less than 50% or an INR of more than 1.7 on post-op day 5, there is a 50% chance that this patient is likely to succumb to post-hepatectomy liver failure. There has been a classification of post-hepatectomy liver failure, grade A, B, and C, depending on what you really need to do to treat the patients. And of course, the mortality will progressively increase as the grade of liver failure would increase. So how do you really decide what are the chances of basically increasing liver failure? We have already said that if greater the amount of liver removed, lesser is the amount of liver that is likely to be left back. Excessive blood loss, and of course, if you further add the operation with vascular reconstruction, biliary reconstruction, have medical comorbidities, the chance of developing post-hepatectomy liver failure progressively increases. And then, of course, we have the volume measurements. How much liver is really safe to be removed? Well, you could remove up to 70 to 80%, as is depicted in this graph. But of course, if you have a compromised liver in the background liver with either steatosis or cholestasis, the amount of liver that needs to be left back has to progressively increase. So you need at least a minimum of 40% of liver to be left back when you're dealing with chronic parenchymal liver disease or cirrhosis. And when you look at this, when you interpret this in terms of graft to body weight ratio, meaning the weight of the liver to the body weight, it comes to around 0.8. Now, this terminology has been adapted from living donor liver transplantation, but 0.8 of graft to body weight roughly corresponds, or actually does correspond to 40% minimal volume of the future remnant liver. And when you look at translate it in terms of liver required per meter square, you require at least 250 ml of liver. And nowadays, with dedicated software on the computer, we are able to calculate the liver volumes very well on the CT scan, which gives us good predictability. So here is a case where we had a patient with a high BMI of 37, diabetic, otherwise preserved liver function, very high CEA, large tumor occupying the left lateral segment, you can see. And this patient essentially otherwise had a good amount of liver remnant. And we did some basic calculations here for the liver remnant. This is just for the sake of illustration, although in this patient it wouldn't have mattered because he qualified to receive a left lateral segmentectomy. But this is how we would calculate the liver volumes and understand that how much will be removed and how much will be left back. I would just come to that again in some time. Now, this is a Japanese classification where there is this Makuchi's algorithm to understand as to how can you plan a hepatectomy. So if a patient comes in with ascites, you look at these things. If you have uncontrolled ascites, you don't forward for an hepatectomy. But if you can control the ascites, you then look at the bilirubin levels and then go on to do an ICG clearance studies and subsequently decide what type of liver resection the patient would qualify for. These are another set of guidelines which have been published in the Journal of Hepatology in 2018. Again, essentially what I'm trying to say is that all guidelines look at synthetic liver function, which means MELD scores, and you look at basically the volume of liver that is going to be left behind, and it's a combination of synthetic function and liver volumetry. So when you plan a liver resection, basically you look at where the lesions are located. You need at least a 33% of remnant liver. You may need to have it greater if you are dealing with a steatotic or a chemosteatotic liver or a cirrhotic liver. And what you need is a good inflow, arterial and portal. You need an adequate outflow from the sectors which are being left back, and a good biliary drainage from the sector which is there. I think we've discussed this slide again. And there are a few methods to increase the liver remnant when you are faced with the problem of removing too much liver and leaving too little behind. At this point, we can make use of the dual blood flow into the liver. We do know that there is a right and a left portal vein. And if you want to increase the volume of the left lobe, because very often we do see that we feel handicapped as the volume is lesser, we do a right-sided portal vein embolization. Particularly for a very large tumor like this, this patient had a very large tumor, occupied most of the right lobe and went into segment 4. You can see the left lateral segment was very small. This patient had a right-sided portal vein embolization. And then you see there was a marked increase in the left lateral segment before this patient underwent a right hepatectomy. Sometimes a portal vein embolization alone does not suffice, and certain innovative approaches have been used in liver surgery to cause hypertrophy and bring about complete removal of all the liver tumors. ALPS is one of the methods associating liver partition and portal vein ligation for a staged hepatectomy. You could use it, especially when there are bilobal liver metastases, and portal vein embolization has not worked very well. It does have a significant morbidity and has not been very popularly continued to be used. And various modifications of the original ALPS procedures have also been described in the surgical literature. This is another patient with a very large HCC occupying almost the entire right lobe, had a little bit of a perforation. And here again, we were faced with the dilemma of expanding the left lobe volume before we could surgically treat this particular patient. At the same time, we wanted to have a treatment of his HCC first. So we followed a staged procedure where he had a TACE first for the right lobe tumor. This was followed by a right-sided portal vein embolization, and the total liver volume expanded, the left lobe volume expanded, and the patient went through a right hepatectomy after about an interval of 6 weeks. As you see, the graft body weight ratio, which was originally 0.5, went up to 1.01, and there was an increment of his future remnant liver also. I would just end by the last few slides now, that basically there is also this particular situation of chemotherapy-induced steatohepatitis. We see it very often in patients, particularly with colorectal liver metastases, who receive a lot of chemotherapy before qualifying to have an operation. And they typically develop what is called as chemotherapy-associated liver injury or non-alcoholic steatohepatitis. And in these patients also, we basically need to possibly do non-tumoral liver biopsies and understand the liver etiology. So this is in summary a slide. This has a recent publication from the British Journal of Surgery. These are the consensus guidelines to understand the liver function in patients in whom hepatectomy is being planned. It's a paper which is published just a couple of months back in the British Journal of Surgery. It's a consensus statement. It's quite a big flow chart, but essentially what it shows is that you use a combination of methods. You look at the liver volumetry, you identify the volume of the liver that is going to be left back. You look at portal hypertension, you look at hepatic venous pressure gradient wherever required. You could do ICG studies or similar studies like LIMAX, scintigraphy. And there are some newer studies like measuring splenic stiffness, doing an US guided portal pressure measurement. You could do a gadolinium tagged MRI using the intracellular or the intrahepatocyte contrast. These are some of the later methods to understand the liver function and plan the operation. So all in all, you look at the anatomy, look at the scan, look at the vascular imaging, biliary anatomy. You could use an intraop cholangiogram. For liver tumors, biopsy is not always required, depends on the situation. But as a rule, if the tumor is operable, you do not do a biopsy unless you are putting them into some kind of a trial or maybe want to give some upfront treatment or want to do some molecular markers. And then, of course, you do volumetry. There is also an expanding role of yttrium-90 trans arterial radioembolization to cause, and this is a double-edged weapon because it can treat the liver tumor. Unlike portal vein embolization, it treats the liver tumor, and at the same time, by causing a radiation lobectomy or a radiation segmentectomy, it causes contralateral hypertrophy of the remnant, which is going to remain behind. So this is one of the newer methods. Although it is costly, it's not very being popularly used, but it does produce significant hypertrophy. And then you could use a combination of methods. So I think I'll end there. Once again, I'll be happy to take any questions at the end of this session. Thank you, Vikas.
Thanks, Somil. Really nice presentations so that we can judge when to operate and when not to operate as it comes, especially in the liver surgeries, which patient is fit for the liver surgery. Now we can start with Dr. Kanchan's presentations. I hope she can do it from her own end. Dr. Kanchan.
Yes, I'll share it. Is my screen visible?
Yes, it's visible, but I think you are playing from the two different devices are nearby. You have to keep the another device far away.
Yeah.
It's echoing.
Okay. Am I audible?
Yes, yes.
So at the outset, I would like to thank you and TUGSS Group for inviting me for this talk on different liver resection techniques. It's a broad topic, but I'll try to do justice with this topic. So greetings from Jupiter Hospital at Thane. So
Dr. Kanchan.
Yes.
Hello.
Hello.
Hello, Dr. Kanchan. Can you please minimize your Zoom window because my own screen is coming on that. Yes. Okay.
Is that all right?
Uh,
Is that all right?
yeah, now it's fine.
Okay. Okay, fine. So, as we all know, the basis for our hepatobiliary surgeries comes from the robust regenerative capacity of the liver, as already seen in the Greek mythology from Prometheus. And basically, for any surgical planning for liver surgeries, we have to understand the patient and the liver anatomy from outside in and from inside out. So you need to see whether the patient's performance status is good enough, whether the patient has a good child-pux score, adequate liver functions, what is the morphology, whether the patient's liver is cirrhotic or non-cirrhotic, associated or not associated with portal hypertension, whether there is any obstructive jaundice which needs to be drained preoperatively, what is the total liver volume, future liver remnant, and if you are resecting for a tumor, then whether it is a benign or malignant tumor, bilobar or unifocal tumor, and whether or not the associated vessels, the vascular pedicles are involved or not. And your liver is naive or it is a post-treatment liver with some part of steatohepatitis or sinusoidal obstruction. So all these things will help you in understanding whether your indication for surgery is true and whether the tumor is resectable or not. So you have to understand that resectability is based on what you are preserving behind and not just by what you are going to remove. So if you understand this, then by your thorough knowledge of your surgical anatomy, you can do all the surgical resections. So the various indications that we know about is benign indications like hepatic adenomas, you have biliary cyst adenomas, then you, in some selected cases of hepatic hemangiomas, you require hepatectomies. And otherwise, we do it for routinely for malignant etiologies like primary HCC, cholangiocarcinoma, hilar cholangiocarcinoma, and secondaries from various other tumors, especially colorectal liver metastasis. So different indications have different approaches. You need to prepare the patient well. The coagulopathy needs to be corrected. Patient has to be well pre-optimized and prehabilitated. If the patient requires a preoperative biliary drainage, that has to be done, and the jaundice has to be lowered. Adequate blood products should be ready. Patient should have a DVT prophylaxis and an antibiotic prophylaxis. So what you need on table is the patient should be supine and there should be an adequate exposure from the nipple to below umbilicus. You should have a good exposure with the help of good retractors like a Thompson retractor, DVT stockings, Frendenberg position if required, and low CVP hypotensive anesthesia, and your incision based on the kind of tumor that you are going to resect or the surgical planning that you have prepared for. So what needs to be thorough in your pre-planning is that based on your pre-operative imaging as rightly shown by Dr. Balakrishnan and Dr. Vyas, pre-operative imaging and surgical planning will tell you whether the tumor is resectable or unresectable. Only then when you have a thorough knowledge of your surgical planes and you see the anatomical variations, based on that you can understand what kind of resection you can plan, and the various control techniques, vascular control techniques, which will help you in decreasing the blood loss during surgery, and whether the patient based on the etiology requires an anatomical or a non-anatomical resection. So based on the Brisbane's terminology, you can go ahead with a formal right or left hepatectomy in the first order division. Based on the second order division, you have sectionectomies now. So it can be a right anterior, right posterior sectionectomy, left medial, left lateral sectionectomy. It's all based on the scissuras, the portal scissuras, and the portal pedicles. And based on the third order division, you can go to the pedicle to each segment and do a segmentectomy or a bisegmentectomy. So major hepatectomy involves 3 or more than 3 liver segments, and minor is 2 or less than 2 liver segments. So basically, you need to understand that doing a major hepatectomy in a cirrhotic liver can be done only, as rightly pointed out by Dr. Vyas, only if there is no ascites, your child-pux score is low, and your ICG retention rate should be less than 10 to 20%. Only then a major hepatectomy can be indicated. So what are the basic surgical principles in any hepatectomy? It's the inflow control, the outflow control, then you go for the parenchymal transection, but do not forget to check the remnant supply and drainage again, so that you don't end up in a post-operative liver failure. So what are your surgical assistants in parenchymal transection? It can be a Kelly clamp crush technique. Nowadays we use more of CUSA. We have hydrojet as well, harmonic scalpel, ligashore can be used, cautery can be used, or the finger fracture technique is relatively obsolete now. So what are the different approaches for inflow? You have the traditional Heiler approach, wherein you dissect the hepatic artery, the portal vein separately. You loop these vessels and then you ligate and divide these vessels to achieve the inflow control. Or it can be the extrafacial and the transfissural approach, commonly known as the Glisonian pedicle approach. So what do you do in the Glisonian pedicle approach is basically what is the Glissen's sheath or the Valiant sheath is the connective tissue around the hepatoduodenal ligament, which encases your portal triad, that is the portal vein, hepatic artery, and the bile duct. And by extrahepatic dissection of this capsule, we can address these structures in the Glissen's pedicle without opening the sheath, thus avoiding the damage to the hepatic portal structures. The only disadvantage with this approach is that it needs a very thorough, solid anatomical knowledge and very good operative skills. The only disadvantage is that it can cause ductal injury when there are anatomical variations. So the traditionally, this is the Glisonian pedicle approach. In the left hand image, you can see that we are isolating the left Glissen's branch at the end of the hilar plate. Okay, after lowering the hilar plate. And the right image, you can see that the right Glissen's pedicle is approached and looped for a right hepatectomy. So what are the different approaches and the parenchymal transection approaches that you have? You also have the anterior approach in the liver hanging maneuver, which is usually used for large tumors, especially in the right lobe, where basically you tend to not mobilize the liver, just do an inflow control, start with the parenchymal transection, then do your outflow control, and then try to mobilize the liver. Because mobilizing the liver has shown to cause a lot of problems like torting the liver. So that torting the liver will cause a rotation of your hepatoduodenal ligament or your IVC or the hepatic veins. Sometimes it might lead to ischemia of your remnant liver, and there is too much pressure kept on the remnant liver. By this method, you can also avoid spillage of the tumor cells, and you can avoid too much of tumor manipulation when there are large tumors, especially in HCCs. So this is how you loop. You create a space between the right and middle hepatic vein, and from down you go in a craniocaudal, caudocranial direction by taking out the small venous tributaries at the caudate lobe junction. And therein you create because there is a loose areolar tissue between the IVC and the liver surface, you can easily create a tunnel, and you can put in a umbilical tape wherein the liver can be hanged just above the vena cava. So this is a case where you have a right-sided 5, 6, 7 tumor, 10 by 11 centimeter tumor, wherein we can do a right hepatectomy. So the standard steps of any right hepatectomy is that you plan your incision well. It could be a subcostal incision, a Mercedes-Benz incision, a Makuchi, or a reverse L incision. First, if you're doing for a malignancy, you rule out your distant metastasis. You divide the ligaments around it. You divide the falciform and the round ligament. The round ligament end can be kept long so that it can assist you for retraction of the liver. You dissect the coronary ligament. You dissect the triangular ligaments. This is how you can dissect your triangular ligament. The liver attachment to the diaphragm is taken out. And then the right lobe of the liver is mobilized from the diaphragm. And then starting from caudally, it is separated from the adrenals. You will find a lot of venous tributaries. You have to ligate it one by one. And then you reach the Makuchi ligament or the right caval ligament, which you have to divide and ligate. because it contains small venous branches. Then you come to the inflow control. You can take a Glisonian pedicle approach, or you can do a hilar dissection and individually loop and ligate the hepatic artery portal vein. The outflow is then ligated, and you can the outflow is then ligated and looped, and then you get a demarcation line, and you can start your parenchymal transection. So this is how your parenchymal transection looks like. And you, in a standard right hepatectomy, you have to be on the right side of your MHP. So any tributaries coming to the segment 7, segment 8 has to be taken out with the on the right of the MHP. And then for the outflow control, you can take a vascular stapler, or you can apply the vascular clamps and just ligate it. This is how your post-resectional surface looks like, after which you have to take control of your hemostasis and look for any biliary leaks. We also use vascular isolation techniques. It can be a Pringles maneuver, a half Pringles maneuver. In few cases, it might help you to decrease the blood loss. What we also have in liver resections is non-anatomical resection, which is done, in this case, it was done for multiple colorectal liver metastasis. A right hepatectomy was done along with non-anatomical resection of these small lesions in the left lobe of the liver. Then the other liver resections, according to the Brisbane's terminology, we have to just follow the surgical planes, and based on the hanging maneuver, you can do all these procedures. So as seen in the images, you can do a right hepatectomy wherein you pass the tape between the left and the right hepatic vein, and then come out between the right and the left portal vein. But if you want to include a right you want to include the 4A and 4B segments in a right.
Dr. Kanchan, I'm not able to hear you. Kanchan?
मैं इसको हिला नहीं पाऊंगी ना स्क्रीन को. Hello, am I audible?
Hello. Yes, now you are audible. We have missed the last slide.
Actually,
actually.
I've logged in from another device, but I'll be showing the same screen.
Okay.
Where did we stop?
Go back to the previous slide, please.
Is it this slide?
You have stopped sharing.
इससे share कर. Can you allow share?
Oh, just a minute. Right now,
Yeah. Is it okay?
yes,
So, have you finished this?
yes, we were yes, we were on this slide. Yes,
Okay. So, so then we have just 1 second. So then we have monosegmentectomies where, as Dr. Balakrishnan rightly pointed out, we can use the knowledge of the cystic plate, the umbilical plate, the hilar plate, and the Arancian plate, and based on that, we can focus on the segmental pedicles and do monosegmentectomies. There are also two-staged approaches in liver resections wherein patients might require a preoperative portal vein embolization due to low FLR, or might require a TACE for a large tumor, or might require an ALPS, which is called as the associating liver partition with portal vein ligation for staged hepatectomy. And in that case, we can do a trisectionectomy for a bilobar liver lesions also. We have also have adjuncts to liver resections wherein we can use a preoperative virtual simulation with 3D softwares which are now available, the Miriam softwares, and intraoperative ultrasound can be used for real-time navigation for the multiple tumors. And also we can use ICG in some tumors, especially in cirrhotic livers, to confirm on our resection margin status. And the various isolation techniques, vascular isolation techniques that we have, which will decrease our blood loss, are the inflow-outflow occlusion and the inflow with outflow occlusion. It can be selective as well as non-selective. So the routinely used is the Pringles maneuver, which can be a continuous one or an intermittent one. An intermittent one, we usually clamp it for 15 to 20 minutes and unclamp it for another 5 minutes. In a continuous one, in a normal liver, you can clamp up to 60 minutes, whereas in pathological livers, which have steatohepatitis or cirrhotic livers, the limit is only 30 minutes. Then you can selectively isolate your vascular pedicles in hemihepatectomies, wherein you isolate and do a Pringles maneuver or a hemi-Pringles maneuver for only the right or the left vascular pedicles. And you can include a hepatic venous occlusion, which is called as a total hepatic vascular occlusion or a selective vascular occlusion in cases which have large tumors and which have high propensity for blood loss. So here I end my talk saying that sound surgical planning in all liver resections is utmost critical. These are complex surgeries, as we know, and should be done in high volume centers. It is associated with a significant risk of morbidity and mortality. And you have to again think about the future liver remnant and not only the resection specimen. So the planning, the surgical planning has to be done taking into account the future liver remnant. There are various advanced technologies available, intraoperative ultrasound and various energy devices, but you should remember that we should not completely substitute our surgical dissections with these high technological instruments. And nowadays, robotic surgeries and laparoscopic liver surgeries are done, especially as a boon to a donor liver hepatectomy, but it still has its own learning curve and it needs expertise. So here is my team from Jupiter Hospital, and I thank you all for patient listening. I'm open to all the questions.
Thanks, Dr. Kanchan. It was really a nice presentation, especially when we are planning for the surgical resection.
Thank you.
Now, I'll just ask all the panelists to come forward and take any questions you want to discuss with the speakers. Dr. Apurva and Dr. Mayank is there.
Hello. Hi. This is Dr. Apurva
Dr.
from
Apurva.
Pune.
Yeah.
Hi. And these were excellent talks by all the three speakers, right from basics to planning for resection and actual execution of the surgery that were discussed in detail. So I think I will invite questions from the forum first so that we can address what are the issues. I think the first question itself was a very interesting question that how do you tackle portal cavernoma during the surgery? But I feel it is very, very difficult to do the surgical liver resections in presence of portal venous thrombosis, portal cavernoma. So I will ask speakers to give their opinion about it.
Hi, this is Saumil Vyas here. Yeah, so I think portal cavernoma is a unique situation.
please.
And it's of course portal vein thrombosis, and then you get reconstitution of the portal flow into the liver via the
Yeah.
cavernoma. And I think this is one of those situations where you don't want to do anything because that is the only source of blood
Yes,
flow into
yes.
the liver. And
Absolutely.
trying to do anything, you would basically interrupt the blood flow into the liver and deprive the liver of portal. So I think in such situations, if you have a liver tumor or whatever, you will have to look for alternative methods, maybe super selective TACE or thermal ablation or a combination of TACE, and one would have to go into that situation. But clearly it would be a contraindication to operate.
I agree. Is there any other opinion?
I agree with Dr. Vyas that we should go with some ablation techniques for these kind of patients.
Mayank, you want to add anything?
Yeah, I would agree on that because any obliteration of the portal flow will hamper any root restrictions. These are not the good candidates for surgery.
Yeah,
Having
sure.
said so, I think it is a very unusual situation where you have to do a liver resection in a patient who has a portal cavernoma. I don't think we come across, I have personally not
Yes.
come across this kind of a situation. So yeah, I mean, yeah.
Dr. Swamil, as you have shown this segment 2 and 3 lesion in one case. So
Yes.
is definitely we need the volumetry in left hepatectomy because the whole of the right lobe liver is remaining there.
Yeah, so I mean, technically, because the right lobe is larger than the left, this was, this lesion was in the left lateral segment. Strictly speaking, you don't need a liver volumetry in a patient who otherwise has normal liver function and in whom you are planning a left lateral sectionectomy, that is a left lateral segmentectomy. But what I want to emphasize, why I have shown that is that it is always a good habit to just institute that particular protocol in your workup so that you are not selective and you are less likely to make mistakes. So I mean, every time you are planning a liver resection, no matter what, it's always a good idea to have a triphasic liver scan, do a CT liver volumetry, get the volumes of the remnant and the liver that is going to be resected, and get a complete 3D reconstruction. So you're basically ticking all the boxes, regardless of what is the kind of resection that you are doing, so that when you actually have to do a major resection, you are less likely to make mistakes, and you have and the radiologist and the team is geared up to look at all this data rather than do it selectively.
So there's another question: is it possible to do the liver resection with hepatic vein thrombosis, Dr. Kanchan?
yes, we have to evaluate if there is a vascular pedicle involved, vascular outflow or inflow is involved, whether you are going to resect, how, first of all, how big is the thrombosis, whether the patient has any extrahepatic metastasis, that you have to rule out first, and whether the thrombosis is extending into the IVC or not. And if you're going to resect the same portion of the liver, if there is a right lobe tumor and your right hepatic vein is involved, there is an extending thrombus into the right hepatic vein, a right hepatectomy should be curative to the patient. But yes, if you have a contralateral lobar venous involvement, then in those cases liver resection is contraindicated. These patients actually tend to have extrahepatic metastasis. The ones who have hepatic venous or IVC thrombosis, these are usually inoperable tumors.
The another person has asked that do you follow the TUGSS formula for liver resection? Dr. Kanchan?
I'm sorry, I'm not aware of the TUGSS formula.
Okay, Dr. Dinesh is there? Dr. Balakrishnan sir, are you there?
Yeah. Sorry. I'm here. I missed the question. What was it?
Okay, I'm also not aware, but someone has asked that do you follow the TUGSS formula for liver resection?
Essentially, the TUGSS concept is, see, actually, before Koino described the segmental anatomy of the liver, Takasaki and his colleagues had also described a similar anatomy. The terminology is slightly different, but essentially, they follow the Glisonian approach. So they also believe that there is a Hyla plate system and that the second order radicals are below, the division is below the plate system. So it's just that the terminology is different. Otherwise, basically it is the same. It's a segmental anatomy and there is a cone system. So they have described the anterior posterior into different cones. And based on that, there is a resection of a tumor. So I don't think it's very different from the Koino description.
Another question is after portal vein embolization, could inflammation or can cause some technical problems in the liver resections? Any one of you can take this question, please.
Yeah, so the success rate of portal vein embolization is about 70%, meaning there will be a 30% chance that the liver is not going to hypertrophy. This may be because of the technical limitations of the procedure, or it could just be that the liver parenchyma is not healthy enough to regenerate, which itself is a very poor prognostic sign and also a negative prognostic factor, and maybe something that will suggest that this patient is likely to go into post-hepatectomy liver failure. So, and of course, there can be inflammation around the area where the portal vein is embolized. It depends on what technique you do, whether you are using a glue cyanoacrylate or whether you're using something where you do lipiodol and then block it. That's a little technical depending on the interventional radiologist. But there is a waiting time of about 6 weeks or so before you take up these patients. Some amount of inflammation is inevitably likely to be present, but it's manageable at surgery most of the times.
Can I just make a small comment in that,
Yes.
Of late we have not been doing much portal vein embolization for liver augmentation. In the sense that, that waiting time, the 4 to 6 waiting time, we have been doing ALPS in selected cases where the volume is very low. It gives very good hypertrophy if your selection is okay. Our main concern is patients with cholangiocarcinomas who may not do as well with ALPS. But in all other cases, we are able to carry out a major resection because in a week's time, the liver regenerates so very well. We can do major extended hepatectomies. So, we have been doing less of portal vein embolization now.
The next question is patient with a large, this is a situational question. If the patient has a large right lobe hepatocellular carcinoma with 2 to 3 suspicious lesions in left lobe, will you go for liver resection or the systemic therapy? I think Dr. Prakash, as you have said, the 2 to 3 suspicious lesions. First, we need to confirm whether it is a metastatic disease or it is just some cystic or some other non-malignant lesions. And even in the suspicious lesion is there, I think the volumetry is more important before excision. Dr. Dinesh.
Basically, if they are, it's not a cirrhotic liver, then if it's a de novo malignancy, not a cirrhotic liver, then only you are considering a major liver resection in HCC. So again, you will have to work up the patient properly. You have to look at the tumor markers, essentially rule out lung mets, because if you have multicentric HCC, especially large, then there is a risk of recurrence is also very high. So you rule out systemic disease, and then probably you can try resecting, especially patients who have virus hepatitis B positive patients, they have better results with resection. You can essentially resect and then probably do some intervention on table RFA, microwave, depending on the location of the tumor.
I believe before resections, we should go for the systemic therapy because if it is a metastatic disease and large HCC is there, so there will be not only the volume problem but also the prognosis of the disease is not good, and even after the resections, he is more prone for the recurrences. Dr. Mike, what do you think?
I would find that in case of liver disease, it's better to go for the surgery first itself. Yes, for suspicious lesions, you add ablative therapies like microwave or RFA on table. They would definitely help resect, provided, yes, as Dr. Dinesh said, other factors need to be in place, volumetries, your remnant liver volumes, overall disease status, and liver status needs to be checked first.
Another question is in SCC after downstaging by systemic chemo, if even in the same situation, we have given the systemic chemotherapy. Is the resection safe? It is if it is within the tumor site prior to downstaging.
See,
Dr.
whenever
Apurva is there?
possible, like
Yeah.
Dr. Mayank is saying, whenever possible, when there is no cirrhosis, you're planning for a resection. I mean, I don't think systemic neoadjuvant therapy followed by resection, I'm not aware. In a normal liver, you plan for a resection. In a patient whom you're planning for a transplant, then probably there is a role for systemic therapy, downsizing, downstaging, and then selecting the appropriate cases for a liver transplant. Because, I mean, that's how I am looking at it.
Yes. What are the selection criteria would be used for the ALPS? Dr. Dinesh, sir, just you have discussed about the ALPS, so you can answer it. The selection criteria used for ALPS.
So again, if the patient is having liver cirrhosis or any liver disease, and the remnant volume is very low, then one should be very wary about doing a procedure like ALPS. So when there is doubt, we would biopsy the remnant volume, the remnant liver. For example, if only segment 2 and 3 is there and there's a large lesion and you have to do an extended right, then you look at the left lobe, how good the left lobe is. If the biopsy is not showing any features of cirrhosis or even inflammation, that's an important factor. As I mentioned before, cholangiocarcinomas, we are a little wary because if you transect, there may be a bile leak, there can be sepsis. So that's another factor that I would consider. But otherwise, what we have seen is that when you have to do an extended right and the volume is very low, doing an ALPS and resecting within 5 to 6 days, especially, I mean, you have to do a full workup, you have to do a PET scan, you have to rule out systemic disease, but you should not have macrovascular venous involvement. All this carries a very high risk for recurrence. But in carefully selected cases, you get about 60% hypertrophy. In 6-7 days, you repeat a CT and go ahead with your planned resection.
There was a question if there's a gallstone with cholecystitis and the thick wall gallbladder, is there any contraindication for the donor liver in those cases? Dr. Kanchan? Unmute yourself. Dr. Kanchan, unmute yourself.
Sorry, I didn't get the question well.
if any patient for the donor hepatectomy, if he's having cholecystitis with the gallstones, so is there any contraindication for the donors?
No, there is no contraindication. You can do the cholecystectomy at the same time.
Okay.
Unless the patient is having sepsis, you can go ahead with doing a donor hepatectomy.
Fine. What other the adjunct will be useful if portal venous embolization is fails? Anyone? Dr. Apurva?
Venous occlusion also can be used, but not many studies with both hepatic venous occlusion and portal vein embolization.
Yeah, and she has right said. The next option, I think, what Dr. Somil has discussed, that ALPS is a possibility, but I also don't think after once the portal vein embolization has already failed, anyone will go for ALPS. So most of the times it is a prior planning that what we are actually going to do, and if we feel that the remnant is too low, then it's better to take upfront decision about what exactly to plan for.
So actually, the technique of portal vein embolization is also important. You have to embolize the
Yes,
segment 4
yes.
branch of the portal vein. If you are not, then you would not get the hypertrophy that you are expecting. That's one thing. One advantage of ALPS is the injury that you cause. The injury also leads to an accelerated hypertrophy. So I don't know whether, along with segment 4 embolization, one should try to do some sort of injury to the liver to get an accelerated hypertrophy.
As we have finished all the questions from the chat box, I invite if panelists want to discuss anything forward.
Yeah, I would just like to ask our speakers that what is their general cutoff values of bilirubin for the planning the liver resections. That will be a very basic thing to discuss. I think everyone will like to know, especially planning for a formal right hepatectomy or a extended resections for cholangiocarcinomas, as well as simple wedge resections for CA gallbladder. What is their experience and their protocol?
Dr. Kanchan here. So basically in hilar cholangio CA, where you have bilirubin less than 15, what I used to practice in my center was not do a preoperative biliary drainage if the patient is well preserved and not showing any signs of sepsis, and go ahead with liver resections. The patients were equally well whether or not you do preoperative biliary drainage in these cases. But if the patient is elderly, the performance is poor, and the patient has any signs of sepsis, then or your bilirubin levels are more than 15, you definitely go ahead with the preoperative biliary drainage.
Yeah, 15 will
Dinesh
be
here.
too high for liver resection, I feel. I think, but it's okay if you're planning. Yes, sir. Dinesh, sir, what is your opinion?
No. I agree with Dr. Kanchan, but of late not of late, last 5 years, our unit has been, accepting a lesser bilirubin value. So we want a value less than 10. Though many Japanese would do reduce the bilirubin to less than 2, we accept a bilirubin,
Yes,
like
yes.
Dr. Kanchan said, if the patient is okay, stable, young patient, less than 10, we
Yeah.
don't do a
Yeah,
drainage.
10, I will agree, sir. Yes, sir. Yes, sir.
More than 10, we tend to drain. Previously, we used to take up these patients and we had some issues of PHLF, longer hospital stay. They don't do as well. Sometimes sepsis.
Yeah.
So less than 10 is what we select. Last 5 years, we've been doing that.
Yeah, maybe I would
Yeah, I
just
think that's
add
better strategy.
yeah.
Yes,
Yeah,
sir.
but well, just one point of view that yes, so we are fundamentally looking at what at a hilar cholangiocarcinoma with obstructive jaundice.
Yes, sir.
So 2 comments. There is a trial by Thomas van Gulik from Amsterdam Medical Center where they showed a bilirubin cutoff of 11.1 as the point at which possibly beyond which you should consider a preoperative biliary drainage. Number one, and particularly you drain the future remnant liver rather than the liver that is going to come out, unless of course you are having a sepsis. So they said that you must drain the contralateral liver, the remnant liver, if your bilirubin is more than 11.1. Number two, it is usually what happens in common practice, and everybody may put your comments here, is that when you do experience jaundice of patients of 11, 12, 13, in this particular range, they also have relative atrophy of one of the contralateral lobes. So it almost becomes invariable that they require volume augmentation of some kind, and you cannot do a volume augmentation in the presence of a jaundice of 10, 11. So it then becomes almost compelling that you drain out the liver, reduce the bilirubin, then perform some kind of volume augmentation, either a PVE or ALPS, but ALPS in a hilar cholangio has, I think, prohibitively high morbidity rates. So in this situation, when you are faced with the challenge of having a borderline liver remnant in the background of significant cholestasis, which itself is not going to allow your liver to hypertrophy, even if you were to embolize, it then becomes almost compelling that you drain the liver remnant, maybe drain the liver that is going to come out, because invariably the obstruction has led to some kind of sepsis. You then embolize the liver, and then before the patient comes up on the operating table. So I think this is also a common clinical situation that one has seen from time to time. Dr. Dinesh, would you like to comment on that?
I completely agree with that, actually. That's been our experience too, that we have to be careful in selecting these patients with cholestatic jaundice. So we do tend to drain, and at our center now, our interventional gastro people are very comfortable putting stents. In the earlier days, we used to do PTBD, but nowadays we are not. They're able to put in stents into the future liver remnant, sometimes both sides, sometimes two stents. And it does help, actually.
Yeah. I mean, that discussion about whether to do it percutaneously or endoscopic is another debate. But I think where the expertise is available, then of course endoscopy can be done rather easily, because it's a one-step procedure, and you don't then have to internalize and do it as a two-step. So yeah, I agree. I mean, you can drain both systems simultaneously, if as far as possible.
Dr. Swami, someone has asked that after doing the portovein embolization, how will you monitor the response of this portovein embolization? Is it weekly CT scan or how?
No, so I think the average time period for hypertrophy of the liver, when you look at the growth rate kinetics, is anywhere between 3 to 6 weeks. So I think you could very well do a scan at the end of 3 to 3 weeks, and then look for signs of hypertrophy. If the liver has not hypertrophied, maybe you just need to give it extra time and look at it at about 6 or maybe up to 8 weeks. But generally, a liver which fails to grow beyond 6 weeks is unlikely to hypertrophy further. And, this is also one of the signs of liver disease or parenchymal liver dysfunction, which is itself a poor prognostic sign. So I think the first CT scan could be done at the end of 3 weeks and maybe 6 weeks, because 6 weeks may just be too long. Apart from looking at the liver hypertrophy, you are also looking for progression of disease. Especially, you could have a situation where you have found that disease has progressed, and then that itself becomes a contraindication to plan a resection.
Dr. Kanchan, are we doing the open liver resections, or we are doing the laparoscopic also at your center?
Very few laparoscopic resections at my center. We do more of open hepatectomies.
I think we have discussed all the topics, and all the chat box questions has already been discussed. And I'm very thankful to all the speakers and all the panelists to take out the sessions. I hope the next time our panelists will be the speakers in the next TUGSS webinars, where we will be discussing more advanced topics on the liver resections and liver surgeries. With that, we have actually completed the 2 years of TUGSS India webinars with this session. And I'm thankful to my TUGSS India team as well for that, for supporting me in all conducting this webinar. And I'm very grateful to all the speakers and faculties for this. Thank you very much. With this, we can end the session.
Thank you, Dr. Vikas. It is nice being here.
Thank you. Thank you, Vikas.
Thank you, Vikas.
Thank you.